My name is Jennifer Sheridan. I'm the Director of Policy here at the Parkinson's Action Network, and it's our pleasure to host this webinar on the Affordable Care Act, and it's an opportunity to educate you about some of the current changes and upcoming changes to our nation's healthcare system. We know that there's a lot of confusion about the Affordable Care Act and what was included in the law, which was actually passed and signed into law in the spring of 2010. While the political debate continues here in Washington on the implementation of the Affordable Care Act, we want to make sure that the Parkinson's community is aware of the changes that are currently happening and what the impact means for our community. While the Parkinson's Action Network has not taken a formal position on the Affordable Care Act, we have strongly supported a number of key changes that were included in the law, including those that expanded coverage for millions of uninsured Americans, ending the prohibition of coverage for pre-existing conditions, and expanding preventive health services, to name a few. We truly hope that this webinar is educational, and as Jamie mentioned, we do hope that you'll have a chance to ask your questions. Technical difficulty. We have spent a lot of time really looking through the law, trying to make sure we understand the impact on the Parkinson's community, and have spent the last several weeks collecting resources that we think are helpful for you as you navigate this new health landscape. So this is an opportunity to walk through some of those changes, talk about some of the resources that are currently available on our website, and we look forward to monitoring implementation of the Affordable Care Act as the health exchanges get up and running this fall. I think I just want to make sure that those on the webinar and the phone understand is we are very much open to understanding what the hurdles are for you and your family and your communities in the healthcare system. And so if there are questions, concerns, or hurdles that you are facing, we want to know what those are so that we can hopefully make sure that the process is working for us. So with that, I'm going to turn it over to Jamie, who's going to walk through some of the highlights of the law.
Thanks, Jen. And so we're going to start today with some of the good, some of the good things that have happened as a result of the Affordable Care Act. A lot of these things you may already know, some you may not. First of all, since it was signed into law in 2010, one of the biggest things that's going to take effect beginning next year is that insurance plans will no longer be able to deny coverage for pre-existing conditions like Parkinson's. There will also be no more lifetime coverage limits. Annual coverage limits will also no longer be permitted. And for both Medicare and Medicaid, and looking on the private insurance side, many preventive health services, including wellness visits, depression screenings, and immunizations, will be offered at no or significantly reduced cost. So now I want to talk about a part of the law that is pretty readily misunderstood. This is the individual mandate piece. And what this is beginning next year, all Americans, with some exceptions, will be required to have health insurance. The good news is that if you already have qualified insurance coverage, you meet this requirement, you don't have to worry about any penalties or any sort of other issues related to your coverage. What does it mean to have qualified coverage? These include government-sponsored plans like Medicare, Medicaid, TRICARE, the Veterans Health Care Programs. This also includes employer-sponsored health insurance and individual private coverage. As I said before, there are some exceptions. For example, you may be exempt from this insurance requirement for certain certified religious reasons. If you have an extremely low income, Native Americans are also exempt from the requirement from the individual mandate. So now that we have the individual mandate and the requirement that everyone has insurance next year, one of the ways the law sought to address this issue was the creation of the health insurance exchanges. And these are the state state-based marketplaces through which individuals and small employers can purchase health insurance. You may have seen they opened nationwide a week ago on October 1st. Each state's exchange will look a little differently. There are three different forms. There's just a straight state-run exchange, so the state will completely operate and facilitate the introduction of plans, managing of plans, and providing information and opportunities for people to sign up. There are the federally facilitated exchanges, which are being run by the federal government through the states, and there are also a few states that have opted to work with the federal government and have a partnership mechanism where the federal government is running the exchange, but the states are actually managing the plans. As I said before, every state's going to have their own exchange, regardless of whether or not it is run by the federal government or it takes one of the other two forms. Plans in the exchanges will have to meet certain standards, and we'll get to that in just a moment. But the exchanges themselves will operate very differently state by state, and I think that's something that we've seen pretty clearly and throughout this past week as the rollout has begun. So if you look on the screen now, there's a map that will give you a better sense of how each state's exchange is organized. One of the best ways to find out if you're not sure what kind of exchange you have is to go on to healthcare.gov and use their Find My State feature. There are also tools online on healthcare.gov to help you find local assistance. If you have any questions, localhelp.healthcare.org. You go on the site, you type in your zip code, and a list will populate that will tell you about local organizations and individuals in your area that are trained and qualified to talk you through the application process, to talk more about what options are available in your area, and to let you know what assistance, if any, you may qualify for. The navigators are a broader community organized group that are doing a lot of work of organizing the application assisters and certified application counselors. Whenever you do enter your zip code on localhelp.healthcare.org, the first list you'll see will be the list of navigator organizations in your area. Most have hotlines and helplines. Most will also have daily office hours for if you'd like to go in and talk to someone face-to-face. That is also available. Healthcare.gov also has a 24-hour, 7-day-a-week helpline, 1-800-318-2596. You can speak directly with the consumer representative to talk about your options, to go through any questions you have, and to see how your exchange and how the plans in your area are organized. Now, as Jennifer said, like we certainly understand, and we've gone on healthcare.gov ourselves. We've gone through the process, and there have been a number of issues reported with online access. Some of these are continuing even into this week. There have been certainly capacity issues and technical glitches. What we found very broadly is that there seems to be a difference in experience between the state-run exchanges and those facilitated through healthcare.gov. We'll make two notes about the state-run exchanges. If you live in Hawaii, your exchange is not yet functional. They're working very hard to get that up. And also, if you live in Oregon, you're able to go on now through your Oregon State Exchange. You can compare plans, but they do not yet have a process for you to sign up online. There are paper applications available at the local assistance areas in Oregon. The process is still ongoing. If you continue to have issues, as Jennifer said, it's very important to let us know, especially as we get further on into the month and into November. There's still some time that, if you don't have to make a decision right now if you're going to be purchasing through your health insurance exchange. In order to have insurance in place by January 1st, you have to have made a decision by December 15th. That does give a little bit of time. Certainly the government shutdown has complicated a little bit of how the federally facilitated exchanges have worked, but that's something that they're continuing to try to improve upon as we go forward. So with the exchanges, who qualifies? Well, the exchanges are designed, as I said before, for those who either don't have insurance coverage or those who currently purchase on the private market. These may include early pre-Medicare eligible retirees, the self-employed, individuals whose employers do not provide insurance, and also those whose employers may provide insurance, but the insurance is deemed as unaffordable. And all that means is that if you have insurance through your employer and the premiums are greater than 9.5% of your income, then your your insurance is deemed unaffordable, and when that happens, you can go on to the healthcare exchange in your state and purchase coverage outside of that employer coverage arrangement. So who doesn't purchase insurance coverage through the exchange? Well, this is anyone who already has existing public or private coverage. If you have Medicare, if you have Medicaid, if you have veterans health, if you're a veterans health beneficiary, if you have private insurance that you want to keep, if you have a private insurance arrangement through your employer that you're happy with, you're under no obligation to move on and go to your state's exchange. And just to clarify one more time, if you have Medicare, if you have Medicaid, if you have any type of publicly assisted insurance, the exchange is not for you. You don't have to be concerned about it. Your options for Medicare will continue as they always have in the past. Now I want to talk a little bit about what the plans are going to look like in the various exchanges. Beginning in 2014, all new and renewed private insurance plans, including those offered in your state-based exchange or insurance marketplace, will have to meet new standardized requirements. Under the Affordable Care Act, insurers will be required to offer plans that fit within 4 levels of coverage. You may have heard about these. They have 4 different levels based on metals: bronze, silver, gold, and platinum. They are arranged by how much of the cost of your health coverage the plan will cover. Bronze plans, they have a minimum of coverage of 60% of your health costs. Silver plans cover a minimum of 70% of your health costs. Gold 80%, and platinum 90%. For example, if you have a silver plan, at a minimum, the silver plan will cover 70% of your health care costs for the year. We have found, we've heard from some folks who've gone through the process and actually enrolled, that some plans, the coverage levels are actually much higher than the minimum. And as I said, the 60, 70, 80, and 90 are just minimum floors for this type of coverage. You may find that your plan is covering a little bit more depending on where you live and the type of coverage options that you have. And in terms of the plans of the exchanges, there's another key piece, and I'm going to turn it over to Jen, because Pam's done a lot of great work with the essential health benefits. It's a very key piece of how these plans are structured and organized and the types of benefits they have to cover.
So as Jamie mentioned, the plans that are covered, that are included in the exchanges, each have to have a minimum set of benefits they offer, and they're called essential health benefits. And as the chart on the screen shows, there are 10 different categories of essential health benefits, including ambulatory services, emergency services, hospitalizations, maternity and newborn care, mental health and substance abuse, prescription drugs, rehabilitative and habilitative services, laboratory services, a bunch of preventive and wellness and chronic disease management services, and then pediatric services. And as Jamie mentioned, the Parkinson's Action Network has done a lot of work in this space because we wanted to make sure that the essential health benefits ensured that they worked for the Parkinson's community. And so one of the main things that we worked on was making sure that the prescription drug coverage was going to be as robust as possible, and that there were standards in place to make sure that people could appeal in case there are any concerns or questions about whether or not a service was needed, that there were appeals processes in place for folks to gain access to medically necessary services. Some of the work that we did included letters to the Secretary of Health and Human Services that were signed on by hundreds of nonprofit healthcare organizations here in Washington, as well as individual letters to the Secretary and the government on behalf of the Parkinson's community. So just to dig in a little bit, around prescription drugs. Prescription drug coverage, as I said, is one of the 10 benefits included in the essential health benefit packages that have to be offered as part of all new private, individual, or small group market plans, including those in and outside of the exchanges. It's a little bit complicated, but plans must cover the greater of at least one drug per category or class, or the same number of prescription drugs in each category and class as your state's benchmark plan, so whichever is greater. And the state benchmark plan basically is each state had to pick a benchmark that is the model for what the plans offered in their exchanges are going to look like. Very often the benchmark was kind of a mid-sized government, state government plan that offers a pretty decent prescription formulary. Those are the drugs that are offered. So this means that if your state's benchmark plan covers 4 drugs in a particular class, then these 4 drugs must be covered as part of a prescription drug coverage for new and individual and small group market plans. At least one drug will be available for each category and class, but in most cases it will very much likely be more than that. For example, the South Carolina benchmark covers 13 total anti-Parkinson medications, and that there are at least 2 drugs in each class. Part of the reason why we spent a lot of time on this is originally the government proposed only having one drug per class or category on the drug formulary. The Parkinson's community, along with many other disease advocacy communities, realized that that was not an option for our population. We want to make sure that we have a variety of drugs available to make sure that people are getting the best care possible. And so we were pleased that the government did change the rule a little bit to make sure that it's much more open to having a more robust drug formulary. Also wanted to talk a little bit about medical necessity and making sure that people have access to drugs that aren't on the drug formulary. Plans must have procedures in place to ensure enrollees have access to medically necessary drugs that are not included on the plan's list of approved drugs known as the formulary. We reiterated time and time again that this was extremely important to people who are on multiple chronic, have chronic diseases and have multiple drugs that they're taking. People want to have access to the drug that works for them, and so making sure that there are procedures in place to be able to do that is extremely important. Just as a resource, if you're interested in looking at what your state benchmark plan looks like, the Center for Medicare and Medicaid Services, Center for Consumer Information and Insurance Oversight, also known as CISIO, the government, we have to have as many acronyms as possible. CISIO has a comprehensive list of each state's essential health benefit benchmark insurance plans, which does include the category and classes of prescription drugs that must be covered. Prescription drug formularies, if you're interested in looking at those, should also be available as you compare your health plans on healthcare.gov or your state's insurance exchange website. So that's just a little bit of information about prescription drugs, and certainly as the plans get up and running, we're going to be very interested to hear any concerns with access to prescription drugs or other services for folks who are in the exchange, and we'll definitely be keeping an ear to the ground to make sure that those are working the way that they should.
All right. Thanks so much, Jennifer. I just want to say for a moment, if you do have questions, please feel free to post them as we go along. We will certainly try to take periodic breaks to address any questions that may come up, and we really do appreciate them. So I want to talk a little bit about how this is going to work in terms of how to afford the insurance. Now that we have an individual mandate, now that there are health insurance exchanges in states, and these are really designed to help to get the uninsured into the market for low to modest income people, there was a recognition that this could really be a strain, adding these extra costs. So one of the things that the Affordable Care Act does is create premium assistance credits. Beginning next year, the law authorizes premium assistance tax credits to help low and middle income individuals and families purchase insurance coverage through the insurance exchanges or marketplaces. And I will make a point that these premium credits are only available to purchase insurance through the exchanges, and they're only available to people who qualify to purchase insurance through the exchanges. So who is eligible? Citizens and legal residents, including families with incomes between 100% and 400% of the federal poverty level. To give you an example of what this looks like, in 2013, 100% of the federal poverty level for an individual is around $11,500. It's a little over $23,500 for a family of four. At the higher end of the spectrum, at 400% of the federal poverty level, an individual, it's around $45,960. For a family of four, just a little over $94,000 for the year. People who's not eligible, if you're eligible for public coverage, so if you're eligible to either have Medicare or Medicaid, or if you have Medicare or Medicaid, you cannot receive premium assistance to purchase through the exchanges. Also, if you're offered coverage through your employer and that coverage is deemed affordable, and again, this is any insurance, your premiums are less than 9.5% of your income for that year, you certainly have the option to leave your employer coverage and go to the exchanges, but unless your coverage is deemed unaffordable, you will not qualify for the premium assistance credits. One quick note before moving on: if you're unaware of where your income falls in the threshold, that's perfectly okay. There are tools and resources, one of which we will get to in just a moment, about how to figure that out, how to calculate it. Healthcare.gov does have a tool that is working sporadically now. There are a few other private groups that have tools together. We'll discuss those in a moment, but it'll help you get a better sense of whether or not you would qualify and for how much. So let's talk a little bit about how this works, and it's a little complicated, so we'll try to hit the high points. So the amount of the tax credit that a person can receive is based on the premium cost of the silver plan in the exchange and state where the person is eligible to purchase coverage. So this means that the value of the credit is going to vary from state to state. A silver plan in your area, let's say in South Carolina, the actual value may differ broadly from the silver plan, let's say in Arkansas or Tennessee. And there's another factor at play when calculating these premium credits, and the second factor is that for people with incomes between 100% and 400% of the federal poverty level, the maximum cost of your health insurance premiums is capped. So if you're at the higher end at 400%, and 400% and beyond, in a sense, for everyone, your insurance premiums cannot be any more than 9.5% of your income. If you're at the lower end of the income scale, the premium limit, the amount you'd have to pay out of pocket for your premiums every year, could be as low as 2% of your income. It cannot exceed that ceiling. So I have a quick example on screen, very simple, of how this may work. Let's say John is single, has an income of 250% of the federal poverty level, which is around $28,700. The cost for the for the lowest mid-tier plan in his exchange, the silver plan in his exchange, is around, a little over $5,000. So under the premium limits, John's not required to pay any more than a little over 8% of his income, which is about $2,000 to enroll in the mid-tier plan. To figure out exactly or roughly what his credit would be, you just subtract what the premium for the plan would be, subtract the income limit to get the credit. There are a few other factors at play that will help determine this credit. So this is really just a good example. It may not be as simple as this in every case. For most all cases, the Kaiser Family Foundation has a very wonderful tool in place. Would certainly recommend checking out a number of their resources. This tool is great. Healthcare.gov is actually using it as a substitute right now while they work on their own internal calculator. It asks a series of questions. It'll help you determine through your income what you may qualify for in your state in terms of a premium assistance credit. And I'll pause here for a moment because I do think we have a question.
Jamie, the question is, do non-exchange plans, i.e. Medicare, employee-provided plans, have to meet the same requirements? And I'm assuming the requirements of the essential health benefits.
That's a fantastic question, and the answer is yes. Especially the essential health benefits will be a part of well, I should qualify that at least first for next year. For non-grandfathered plans, there are some individual plans that will have a waiver next year and will not be required to do the same essential health benefits. Beginning in 2015, though, this will apply to all new plans, both on the private market and those through public care, both Medicare and Medicaid. So that's a great question.
And just as a reminder, if there are questions, feel free to type them in. It's a little talk bubble to the left of the little computer thing that's going like this. So feel free to type those in as Jamie continues speaking.
And we're very quickly just going to go through like everything that Jen and I we just talked about in terms of resources available on the healthcare exchanges. Healthcare.gov is a fantastic place, even though there are some glitches and issues. The Find Your Exchange feature has been working very well. The Finding Local Assistance feature has not been impacted by, and this is the localhelp.healthcare.org. There's, again, the 24/7 consumer hotline. There's also a chat services area where you can go in and interact with a consumer representative as you are going through the application process. And if you're interested in getting links to all this information, please visit parkinsonsaction.org/ACA-resources. We have links to all these resources and more, and a lot more we're going to get to when we talk about Medicare and Medicaid going forward. One thing that I do want to say that I don't think I made very clear at the beginning is that if you are in a state that has a state-run exchange, you may go on healthcare.gov the first time to determine where you are and how to get to your state's website. After that point, if you have a state-run exchange, it's very likely you will not have to go back to healthcare.gov for any reason. Your state's exchange will be handling the application processes, talking through options with you, and providing the comparisons that you'll need. If, on the other hand, if your state is going to be if your state's exchange is operated primarily through the federal government, you will continue to use healthcare.gov as your primary source of information. All right, so let's go through the Affordable Care Act and Medicare. And there's been a lot of confusion. We've certainly heard from folks in the community. We've heard, we've seen it in the news, and there hasn't been a great understanding or communication of how the Affordable Care Act really is going to impact your Medicare coverage. By and large, if you have Medicare coverage now, your choices and level of coverage, you shouldn't see many, if any at all, negative changes. Your open enrollment dates are going to remain the same. October 15th will remain the same date for open enrollment. You may or should have already seen some notable boosts to your benefits. As I said, maybe at the top of the call, free preventative services, there are expanded wellness visits, immunizations, there are now depression and cancer screenings. Another thing that the Affordable Care Act does, and we'll talk about this in a little more detail in just a moment, is that it begins to phase out the Medicare Part D donut hole and make some pretty significant changes to the way that prescription drugs are covered. We will say that because of the government shutdown, there may be some impact on your open enrollment experience through Medicaid. This has not been confirmed. Most of the work to provide plan options and to update information should have been done prior to October 1st in the shutdown. If you do have any issues, any personal issues at all in terms of your enrollment experience or access through Medicare.gov, please let us know, and we will do what we can to communicate that and to see if whatever we can do to help alleviate those issues. So Medicare Part D. If you have Part D prescription drug coverage, you should have already seen some changes since the law was signed in 2010. And then prior to this point, Medicare Part D, when it took effect in 2006, enrollees were required to pay 100% of their prescription drug cost after their total spending reached a certain amount until they began to qualify for catastrophic coverage. And many of you know this very well as the donut hole. And what the Affordable Care Act does is it gradually reduces the amount that Medicare Part D enrollees have to pay out of pocket in that coverage gap, and it will virtually eliminate the coverage gap by 2020. And I want to pause here again just one moment. We have heard a few isolated cases from people in the community that they've seen certain drug costs shift significantly since some of these changes have gone into place. In some cases, the cost of generic drugs has begun to skyrocket. If you have experiences with this, if you know others in the Parkinson's community that have had drug costs that have shifted dramatically in the past couple of years, this is something that we certainly want to know about. We are monitoring it very closely. We're trying to get answers as much as we can about some of the limited and isolated cases that we've heard, but we certainly don't want this to become a more widespread problem, and if it does, we want to be on top of it and communicating the issues with the folks at CMS and Medicare as soon as possible. Just wanted to put that out there, and please let us know. We certainly hope this will not become a more widespread issue, but if it does, we want to be prepared for it. So look on the screen. There are two graphs that show exactly how these changes are supposed to work. Very broadly, by 2020, for brand name drugs, Part D enrollees will receive a 50% discount from pharmaceutical manufacturers, plus a 25% federal subsidy, which would limit their out-of-pocket costs and the coverage gap to 25%. For generic drugs, you see the same shift in cost. 75% of their total cost by 2020 will be subsidized directly by Medicare, and this will limit any out-of-pocket expenses that you would have to pay in that middle period to 25% for all Part D enrollees. I want to talk briefly about the Affordable Care Act and Medicare Advantage. Many of you know that Medicare Advantage plans allow Medicare enrollees to receive their benefits through private health plans as an alternative to the traditional federally administered Medicare program. Over time, the federal payments to the Advantage plans have grown significantly, and in efforts to expand access to private plans and provide additional benefits, as one of the cost savings measures in the Affordable Care Act, payments to Medicare Advantage plans have been gradually reduced in an effort to bring their total cost closer to what we see year by year for traditional Medicare. Starting next year, Medicare Advantage plans will be required to maintain a medical loss ratio, and what this is the amount of money that the plan has to spend on your medical care of 85%. This will restrict the share of federal payments and premiums that Medicare Advantage companies can use for administrative purposes, for profits, and for some of the additional extra benefits they've been offering. These changes are designed to ensure that a higher percentage of payments are directed directly toward medical services, but if you have a Medicare Advantage plan, it is possible that you may begin to notice some modifications to your coverage, probably beginning as soon as a couple of years back, but they may become more pronounced as we move forward. The effects of the reductions in payments will likely vary state by state and by insurer. Some areas you may see absolutely no changes. You wouldn't have known that anything at all had shifted with your coverage. In others, there may be a reduction in the number of Medicare Advantage plans offered. There also may be while the traditional benefits are covered, you might see higher premiums. You might also see increased cost sharing, although this will be subject to limitations. Again, the network of providers may shrink a little bit, and the extra benefits, dental care, eyeglasses, all of these may be subject to reductions or cuts moving forward with the Medicare Advantage plans. And very quickly, if you have Medigap or Medicare supplemental insurance, there are no significant changes to the way you purchase or manage your coverage. The enrollment process remains the same, and you can visit Medicare.gov to shop and compare Medigap coverage plans in your area. One thing I want to note about Medigap, and we've gotten some questions about this recently, Medigap plans do not have to follow the Affordable Care Act mandate that requires health plans to cover pre-existing conditions. There are some plans that may continue to make you wait up to 6 months before your coverage will begin. Not all plans are following this requirement. Actually, a number of plans, a number of areas across the country are beginning to waive the waiting period, and they are beginning to cover with pre-existing conditions immediately. However, this is not required of them as a result of the Affordable Care Act. Also, another note, if you are under the age of 65, state plans are not required to offer Medigap coverage to you. You can still purchase it in a number of places, but if you're under the age 65, you may have a little more difficulty finding a plan that meets your needs. And I'll pause there just for a moment to see if we had any questions or anything come in. All right, we'll move on to Medicaid. Medicaid expansion in all 50 states was originally part of the Affordable Care Act. Some of you may remember last summer the Supreme Court ruled that states actually could have the option to opt out of Medicaid expansion. For states that have chosen to expand Medicaid, like California, beginning next year, Medicaid coverage will be available to individuals between the ages of 19 and 65 who have incomes below 133% of the federal poverty level, which is about $15,000, who are citizens or legal residents, who are not incarcerated, and who are also not on Medicare. If you look on the screen up right on the left, the graph will give you a sense of how each state is handling Medicaid expansion. We'll point out that there are a few states, Arkansas being a notable example, and Pennsylvania has recently announced that they're moving in this direction, are looking at alternative Medicaid expansion plans. Arkansas in particular has a model where they're using the Medicaid expansion money from the federal government to create subsidies for low-income individuals to buy through their state's exchange. Pennsylvania is also crafting a very similar model, and we're beginning to see other states that are looking at alternatives as well. And one thing to note is that a state can make a decision to expand Medicaid at any time throughout the coverage year, so this will be something to watch moving forward. The Affordable Care Act makes no changes to current Medicaid eligibility requirements for the aged, blind, disabled, and Social Security income recipients. And as we noted a little bit earlier in the question, Medicaid plans are now required to cover the essential health benefits. If you're interested in learning more about what your state is doing with Medicaid, whether it's expanding or moving forward with the coverage levels it always has, please visit Medicaid.gov. They do have a wonderful Affordable Care Act section that will break down how each state is dealing with the issue. Once again, just to look at all the various Medicare and Medicaid resources that are available, Medicare.gov remains the best resource for all issues related to Medicare, including Medicare Advantage and Medigap policies. There are links on those sites to help you look at plans, compare plans in your area. Medicaid.gov, as I mentioned a minute ago, is a great resource to learn more about what your state is doing in terms of Medicaid expansion. PAN also has a Medicare Medicaid FAQ section on our website, and links to this can be found again on our PAN ACA resources webpage, parkinsonsaction.org/ACA-resources. This is our broad compendium of all the information that you'll need for the Affordable Care Act. So I'll pause one more time to see if we have any questions coming in or any other thoughts. Okay, so in closing, we really appreciate everyone's attention this afternoon, and we want to provide a general list of all the great tools and resources that are available to you. And as Jen mentioned at the top of the call, one of the things that's most important to us is that you feel you have the information that you need to make decisions for you, to help other folks in the Parkinson's community navigate their options. With the ACA, the exchanges, and private insurance, healthcare.gov is a great primary resource. Again, if your state is running its own exchange, after your initial pass through healthcare.gov to find your state's website, chances are you won't have to go back to healthcare.gov, but it still exists as a good resource for broad information on the Affordable Care Act. The hotline, 24 hours a day, 7 days a week, remains available. It's actually been used in a number of cases to help people fill out applications over the phone when the website wasn't working. The Kaiser Family Foundation, kff.org/health-reform, if you want a great overview of how the Affordable Care Act is impacting various parts of the law, impact various parts of the community. It's a great place to go. They do have an interactive cartoon that explains the exchanges in great detail. And, of course, Medicare and Medicaid.gov. All of these resources are available on our Parkinson's Action Network resources page. You'll have direct links. We certainly encourage you to check back often. We will continue to update as new information becomes available as we learn more about how the implementation is moving forward. And if you have questions we didn't get to today, if there's a question you'd like to ask, maybe something a little more personal in nature, please feel free to email me, jtucker@parkinsonsaction.org, or Jennifer at jsheridan@parkinsonsaction.org. We'll be happy to answer your questions. We're going to continue in our weekly newsletter publishing a healthcare question of the week moving forward, so we'll do our best to continue to address things as they come up and to be as proactive as we can in talking through what the changes are going to mean moving forward into next year and beyond. So we certainly appreciate all of your attention today. We appreciate you being on the call and on the webinar. We thank you, and please send us any questions you may have, and we look forward to continuing to reach out over the next few weeks and months and let you know what we're learning and to provide you with as many materials and resources as we can to help you navigate a number of these changes. So thank you very much.